Good afternoon, everyone. We hope you enjoyed a delicious lunch and had a great time together. And now I'd like to invite Dr. Mahesh Ugale, sir, and sir will be shedding light on the topic of Müllerian structures and female reproductive system. Now I would request moderators, Dr. Anjali ma'am or Atul sir to take over the dais.
A very warm good afternoon, respected seniors, dear colleagues, students and friends. My task has become a little more difficult because it's a post-lunch session and circulation is shifted from brain to GIT. So I will try my best to make this topic lighter and let it be like a dessert. Before I start, I would like to express my gratitude and thanks to all organizers, dear Sandeep sir and Kondekar sir and his team for giving me opportunity, as this theme and the topic is very close to my heart. It's a basic concepts and radiological anatomy, because since last 25 years I am teaching anatomy and practicing radiology as well. So I am very excited and happy to share on this dais the topic given to me, Müllerian genesis. So I am going to take you back to nostalgic days of first year with the embryology. So since morning we have listened to very good anatomy talk, gross anatomy, variations. So this is probably the first in embryology, how these structures develop, and unless we know the basis, the anomalies, we may not know from the root. So we are going to discuss first the anatomy of the female genital tract, the different imaging modalities, how to evaluate, then the anomalies of the uterus, vagina, external genitals, ovaries, and then we will conclude. So most of us know that uterus develops from the Müllerian duct, fused Müllerian ducts, and unfused part forms the fallopian tubes. But what is Müllerian duct and from where it comes? So in the first diagram you can see that this is called nephrogenic cord. Can you see? Sir, pointer. So mesoderm is divided into paraxial, intermediate and lateral plate mesoderm. Now we don't have time to tell from where the mesoderm comes. I hope we know that ectoderm, mesoderm and endoderm, the three germ layers are there. Endoderm is forming GIT, gut tube. Ectoderm is forming neural tube and skin, and in between there was a mesoderm. So mesoderm is having paraxial, intermediate and lateral plate, three parts. Paraxial means by the side of axis, by the side of notochord. So this paraxial mesoderm is engaged in dividing into sclerotome, dermatome and myotome. Sclerotome forms vertebrae, dermatome forms migrates and forms dermis, and myotome forms the skeletal muscles. So this is paraxial mesoderm. Intermediate mesoderm, which remains as a longitudinal strip for long period, later on differentiates to form nephrogenic cord, and this is the area which is going to form urogenital system. Laterally there is a lateral plate mesoderm, which is divided by a new cavity called as intraembryonic coelom into somatopleuric and splanchnopluric layer. Somatopleuric layer forms muscles of the body wall, whereas splanchnopluric mesoderm forms muscles of the viscera, that is the GI tract, urinary bladder, uterus, including blood vessels as well. In between the two, the space whatever is called intraembryonic coelom, which is going to form body cavities, that is a pleural, peritoneal and pericardial cavities. So this is the lateral plate mesoderm, this is intermediate, this is paraxial. So this intermediate will focus now, which is rapidly dividing and forming a nephrogenic cord, which is further classified into the medialmost structure, which is developing gonad called as genital reach, then mesonephric tubules, by the side of it mesonephric duct, which is also called Wolffian duct, and paramesonephric duct, which is the Müllerian duct. Today's focus will be on Müllerian duct. On the opposite side, if you see this genital reach from this intermediate mesoderm, it forms connective tissue stromal basis of the gonad, whereas the germ cells, which are actually going to form the gametes, they are migrating from the dorsal wall of the gut, from yolk sac, and going to come and rest here. So there are two distinct sources of formation of the ovaries. By the side of it, there are mesonephric tubules, the caudal part of which is going to form kidney, and mesonephric duct is going to form male reproductive duct, that is vas deferens and epididymis, whereas in females this is going to degenerate. Müllerian duct degenerates in male and it is going to form important uterovaginal canal like this by the side of these gonads. So upper part forms fallopian tube, fused part forms uterus and upper third of the vagina. So we'll see in the next slide. So this is a longitudinal strip vertical called as intermediate mesoderm, and this is yolk sac. From the wall of the gut, these germ cells are going to come and rest here within the genital reach, and gonad is going to be formed. Initially it is a vertical elongated elliptical structure, later on condenses and then descends down. So there are these ovaries, they develop from genital reach, which is intermediate mesoderm, coelomic epithelium, which forms the cortex, and primordial germ cells, which are migrating from such a long distance. These germ cells, if get arrested in between, can form retroperitoneal and mediastinal teratomas, as we know that in cross-sectional radiology. So that was about ovary. We will skip to next, that is a uterovaginal canal. So paramesonephric duct, they fuse in the center and form uterovaginal canal. Unfused part forms fallopian tubes, and this is just behind or posterior to urogenital sinus. What is urogenital sinus? It is a caudal part of hindgut. Hindgut means endoderm. So this is an endodermal structure which is going to form bladder and urethra. That is urogenital sinus. Whereas just posterior to it, uterovaginal canal is there, and the vagina is more complex than uterus in development because it is contributed by endoderm as well as mesoderm. As I have told, mesonephric duct disappears in females, but sometimes parts of it remains as a persistent, some cysts in the broad ligament, which are called cysts of the epiphoron, paraphoron, or sometimes Gartner's duct cyst, as seen in this MR. Gartner's duct cyst. Gartner's duct is nothing but the remnant of the mesonephric duct or Wolffian duct. So vagina is more complex in development. It develops from lower part of the uterovaginal canal, that is a mesodermal part, whereas the lower part of vagina is developed by endoderm, that is from urogenital sinus, which is called sinovaginal bulb. From this endoderm proliferates backward and forms the solid vaginal plate, which later on canalizes by formation of small vacuoles inside it, and they fuse with each other and then communicate with the uterovaginal canal. So as this part is a little more complex, there are chances of some septums to be formed in this junctional part of the vagina. So same thing shown here, this is fused Müllerian ducts, and they are forming uterovaginal canal, which is differentiating into uterus, upper vagina, whereas lower vagina is developed from sinovaginal bulbs, that is endoderm. Unfused part forms fallopian tubes. So external genitals, the perineal membrane after folding forms genital tubercle, genital swellings and genital ridges, which differentiates in male and female differently and form clitoris, labia minora and labia majora. So coming to abnormalities of the development, and these are called Müllerian anomalies. There is a wide spectrum of these anomalies from the normal variants to the extreme atresia and total aplasia. So the causes of these are the hormonal deficiency and excess, sometimes teratogenic causes, chromosomal causes, in that well known is WNT4 mutation, and in most of the cases we don't know the cause, they are accidental. We can investigate these anomalies with the help of conventional X-rays, with the help of HSG by putting contrast in the endometrial cavity. But the most common and the primary modality, ultrasound, more precisely with the endovaginal and 3D ultrasounds. CT has limited role in the evaluation of female genital anomalies because first thing that it is not biosafely, and in reproductive lifespan we should restrict its use, plus it is not as informative as MR because of lack of soft tissue contrast. MR is still gold standard in the evaluation of female genital tract. Non-radiological modalities are hysteroscopy and laparoscopy, which can be diagnostic as well as sometimes therapeutic. So the most accepted classification of the Müllerian anomalies by American Fertility Society is class 1 to 7, in which 1 is total agenesis or severe hypoplasia. Class 2 is unicornate uterus. There are different subtypes. Class 3 is didal phase, which is complete double uterus. Class 4 is bicornate uterus, which is most common anomaly in all these. Class 5 is septate, second commonest. Class 6 is arcuate uterus. It is not actually anomaly, it is a theoretical, but it is a variant. And it will not affect at all in the reproductive life of a woman. Class 7 is an intrauterine exposure to diethylstilbestrol and related abnormalities and distortion of the uterovaginal canal. The first, one by one, we'll see examples of all these 7. First is a Müllerian agenesis, total agenesis, and we can see many times the ovaries are well developed and uterus and vagina are severely atretic or absent. In 15 to 40% cases, it is associated with renal abnormalities. As we have seen normally, how closely the mesonephric tubules they develop with the mesonephric duct and paramesonephric duct. So the more frequent, very frequently we describe in practice MRK syndrome. It has a type A where there are renal, only the urogenital abnormalities, and type B where there are associated kidney abnormalities. Class 2 anomaly is unicornate uterus, and there are subtypes where the other horn may be atropic, totally absent, or stenotic like this. And again, classically we can diagnose it on HSG. The contrast CT by installation, the CT HSG we can call by installation of contrast, or MR without any contrast, very readily diagnosed easily on MR. Next is class 3 uterine diadelphys, fortunately less common, but it is totally double uterus, and it can be again of two types, unicollis and bicollis. We can diagnose it with the help of HSG, MR, gold standard is MR, and it can be bicollis or unicollis depending on the number of cervices. Many times it is having the upper vagina is also double and a longitudinal septum is there, which is total uterine diadelphys. This is a case which we have diagnosed, and on MR without contrast there was only diadelphys uterus, but when the contrast, that is water or jelly, is pushed into the vagina, you can visualize very well this longitudinal septum. It's our duty to give the location, length and thickness of the septum, which helps the clinician to plan for the therapeutic. Next is a bicornate. It is most common of all these anomalies of the uterus, where externally uterus is one, but the shape is heart shaped instead of pear shaped, and there are two separate endometrial cavities with or without the duplication of the cervix. So bicornate unicollis and bicornate bicollis, two types of bicornate uteruses we can see. Second most common is septate uterus, difficult to differentiate from bicornate, but there are some techniques and angles. So I will tell it at the end. And the septate uterus may be complete septum within the endometrium or partial septum. Class 6 is a normal variant, arcuate uterus. So this is normal and this is arcuate uterus. So this length between the upper part of fundus and the indentation, if it is more than 1.5 centimeter, we can call it as a arcuate uterus, which is, it will not interfere with the reproductive life of a woman. Last class is the intrauterine exposure to diethylstilbestrol. It will cause distortion, a T-shaped uterus classically described, vaginal adenosis, the beaded appearance of the fallopian tube, etc. After uterus, second most common uterovaginal anomalies are vaginal, that is Müllerian anomalies, because upper part of vagina is developed from mesoderm, and the junctional zone is at the risk of forming this transverse septum, which can be also called imperforate hymen. Longitudinal septum, as we have just seen it, it's an extreme form of the diadelphys uterus with septate vagina. Double vagina, if the septum is very thick, we can call it double vagina. Severe atresia, total atresia, and agenesis. So these are the abnormalities of vagina. So this is transverse septum, this is longitudinal septum, diagrammatically shown on MR, and here you can see the collection in the lower cervix, sometimes into the upper fornices as well. I will show in the next case. This was a 17-year-old girl with burning micturition, pain in lower abdomen, and distension. So the MR shown, there is a hemorrhagic collection into the fornices and upper vagina, hematocolpus. Above it you can see very normal uterus. So these are coronal and axial images of the same. So this is a transverse septum or imperforate hymen with hematocolpus. Theoretically, their fallopian tube can be elongated, absent on one side, and they may not be noticed, and there is no much literature or images on this. Ovarian abnormalities can be total agenesis because of some chromosomal problems, or accessory ovaries, very rare, and abnormal location into the broad ligament. More common than that is the lobulated ovary, which is shown here, extremely rare ovarian abnormalities. But and these are the cysts associated with the ovary, the cysts of the epiphoron, paraphoron, lobulated ovary. So ovarian abnormalities per se are very rare. This is a germ cell tumor which is actually classified into the ovarian tumors, but its origin, as we have discussed in the beginning, it is by the migration of the germ cell. So it is an embryological cell rests which form these tumors. So even though it is an ovarian tumor, its origin is in the development of ovary, germ cell tumors. And as we have seen, the course of these germ cells is very tedious. They can be arrested anywhere in retroperitoneum or mediastinum. These teratomas, ovarian, can be formed anywhere. So just I thought that I should mention this, even though it is a tumor, in the embryological anomalies of the urogenital tract. Now with this, there is uterus. Everything is there, normal, endometrium, ovaries, but size of the uterus is smaller. And the frequently asked question, is it hypoplastic or normal? So there is no exact demarcation idea, but from prepubertal girls till 10th year, after 10th, there is considerable rise in the volume of the uterus, and whenever in disecase, we have to calculate the volume of the ovary, and it increases from 1.5 to 25.8 square centimeter, and in the multiparous woman, it may go up to the 40 cubic centimeter, and we can give it in the standard deviation format. More than 2 standard deviation variation, we can call is hypertrophic or atrophic or small size. Distinction between didelphys and bicornate uterus. As I have told, bicornate uterus is a heart-shaped uterus. There is one uterus, but instead of being pear-shaped, it is heart-shaped. Whereas in didelphys, there are 2 separate uteruses. More common is bicornate uterus. Second, these are the 2 more common, septate and bicornate uteruses, and the distinction between the two is the angle. If you measure this angle, if it is less than 60 between these 2 horns, it is suggestive of septate uterus, and more than 60 is more consistent with bicornate uterus. Same thing, confusion between arcuate and septate, because if the septum is very small or incomplete or thick one and short length, so it is considered as septate uterus when there is depth more than 15 millimeter from upper point to the endometrium and angle less than 90 degree. While a normal uterus or arcuate uterus should have both indentation depth of 10 millimeter and indentation angle more than 90 degree. And many times we may land up in between these values. So in that cases, uterus, if doesn't fit into these criteria, it should be left as unclassified gray zone. Clinically used, this term is many times hysteroscopist and laparoscopist. Robert's uterus, what is this? So Robert uterus is a rare anomaly of the fusion of the Müllerian duct only, where there is unequal division of the uterine cavity. Patients may present with recurrent pain, dysmenorrhea, abortions and infertility. So you can see here there is unequal, this septum, uterus, there are 2 uterus, 2 cavities unequal, and also there is a collection. Robert's uterus. Another common term used in clinical practice, Ovira syndrome, which is the obstructed hemivagina and ipsilateral renal anomaly. So where the vaginal septum is attached to the side lateral wall of the vagina, and it causes obstruction with the hematometrocolpos. So to conclude, comprehensive preoperative evaluation of the patients with Müllerian abnormalities is essential. Ultrasound and transvaginal ultrasound is important, widely available, economic, and gives comprehensive details. But MRI is the gold standard because of excellent soft tissue contrast and biosafety. What we see in practice is a tip of iceberg, as there is a wide spectrum in population, from normal variants to the severe forms. Thank you all for patient listening. Thank you. Thank you.